We would like to thank the audience that is connected with us at this moment. Today, we are carrying out this activity with the support of Brachy Academy, whom we thank in advance. Today, we will address the subject of liver brachytherapy new strategies. Before we start, we will broadcast a short video in Spanish and then in English on how to activate the simultaneous translation for this talk.
Instrucciones para la traducción simultánea. Primero, dar clic en el botón Interpretación. Segundo, seleccionar el idioma. Tercero, clic en la opción Silenciar el audio original. Importante: nunca debe de estar en check esta opción. Clic en Más. Clic en Interpretación de idiomas. Escoger el idioma. Activar la opción Silenciar el audio original. Clic en Listo.
Instructions for simultaneous translation. First, click on the button Interpretation. Second, select the language. Third, click on the option Mute the original audio. Important: you should never be in check this option. Click on More. Click on Language Interpretation. Choose Language. Activate Mute Original Audio. Click on Done.
Now, I would like to introduce as moderators in today's session, we have Dr. Apolo Salgado, radiation oncologist and director of the radiotherapy department at the National Cancer Institute of Chile. Gustavo Sarria, radiation oncologist at Bonn University in Germany and the director of development at Rayos Contra Cáncer. And myself, David Martinez, radiation oncologist at Auna Corporation in Lima, Peru, and director of education and research for Latin America at Rayos Contra Cáncer. Before we start this session, first of all, we will give some brief instructions regarding the dynamics of participation. The audience will remain in listen-only mode in order to avoid possible audio interference. In the chat box, attendees will be able to ask questions as well as request to speak by raising their hand, where the microphones will be enabled in order of request by the end of the talk in the Q&A session. We would like also to remind you that these and other activities that the organization are doing are available on our YouTube channel, both on brachytherapy, radiosurgery, contouring, and other topics of interest in our specialty. Well, without further ado, I would like to introduce today's speaker. To develop today's topic, I would like to introduce as a speaker to Dr. Stefanie Corradini, clinical expert, radiation oncologist at LMU Munich, Germany, to share her experience in liver brachytherapy. Dr. Corradini will present indications for liver brachytherapy, primary and secondary liver malignancies, technique of interstitial CT-guided liver brachytherapy, collaboration with interventional radiology, benefits compared to SBRT and other local therapies. So, welcome Dr. Corradini. Now you are able to share your screen.
So, Thanks, Apollo, for the introduction, and thanks, David, a lot for the kind invitation to give this talk today. I'm going to share our experience, which we have with interventional radiotherapy or brachytherapy for liver disease. So today, I'm going to talk about primary liver lesions, so mainly about HCCs, hepatocellular carcinoma, and then also about metastasis, and then I will focus on oligometastasis. So we will start with the hepatocellular carcinoma, and briefly the treatment options are obviously surgery, first of all, either only a resection or also a liver transplant. But if the patient is not a candidate for surgery, then other local ablative techniques come in place. First of all, radiofrequency ablation and microwave ablation, but also transarterial chemoembolization, also called TACE. What's the role of radiotherapy within this context? So over the last year, I think that the role has also evolved. So it started with the early stage HCCs, where radiotherapy was mainly used for patients who were not candidates for surgery or for other local ablative therapies. But now it can be also used in more elevated stages of hepatocellular carcinoma, and also like in combination with systemic therapies. Which treatment options do we have in general? Of course, as all of you know, we can do external beam radiotherapy, which usually in the case of liver will be SBRT, but we have also the possibility to do brachytherapy. And I always say, is this a new kid on the block? Well, actually it is not, because we already have a lot of data, and brachytherapy is also already now a treatment option also in international guidelines. Like in the ESMO guideline, that's the European guideline for medical oncology, for the treatment of the hepatocellular carcinoma. You can see that brachytherapy is already now a treatment option for the early stage hepatocellular carcinoma, and it has the same level of evidence as has SBRT, which means that you can treat your patients and you can already refer to a guideline. What are the challenges if you treat liver? Well, basically the most important challenge is that the liver is a moving organ, which means that your patient is breathing.
Está respirando y que tiene un movimiento a gran escala del hígado mientras usted está haciendo la radioterapia.
You need to control for a lot of factors, like for patient setup errors or organ motion, or also patient movement, to ensure that you have a very highly precise treatment if you treat liver. Usually, if we do SBRT for treatment planning, we do a 4D CT, so we can see the movement which the tumor is doing while the patient is breathing. And we use this information for treatment planning, where we usually then use an ITV concept, where we treat the entire region where the tumor is moving, within the region where the tumor is moving, which also means that you treat the lesion, but you also treat a really large volume of healthy liver tissue, which is not, there's no hepatocellular carcinoma, and you treat the healthy liver. We have different treatment options in general in radiation oncology. You can do tracking, or you can do gating or breath hold, only as some examples. But if you're not between the lucky ones who get an MR-Linac, where you have really the ability to see the tumor while you're treating it, as you can see in the image, there you can really see the liver lesion really clearly, and you see if the patient breathes, you see the movement, and you can see it online. If you don't have such a machine, which is like, it costs like millions of euros, it's really expensive, then usually if you want to do SBRT on a conventional Linac, you use fiducials. As you know, on a cone beam CT, you cannot see liver lesions, which makes it very difficult to do the IGRT during the treatment, and therefore there are different kinds of fiducials, which you can see here. They are placed like or in the near of the tumor, and so if you do your cone beam CT, you can see this marker and you can do your IGRT. That's great, and it also works, but what's the problem? Usually we don't do put these fiducials by ourselves into the tumor, and you send the patient to your radiologist, and the radiologist says, perfect, I can put in a fiducial for you, but I can also directly treat the metastasis or the HCC, and therefore the radiologists who usually put in the fiducials, they can do also a thermal ablation, and the intervention is nearly the same. You have a needle, you have to go inside the liver, you have to puncture the liver, and so sometimes it's difficult to get your fiducials placed. The radiologists, they are really trained in doing this. They treat a lot of patients. When they do radiofrequency ablation, this is the needles they put in. And as you can see in this image here, it's like they heat up the lesion from the inside. But also with this technique, there are a lot of uncertainties. For example, it only works really well if the lesion is only 2 to 3 centimeters large, and sometimes they don't know how long they have to heat it up. So it's also not like the perfect solution for some of the lesions. Another point which you really have to think of is that radiofrequency ablation, the needles are really expensive. So one of these needles costs in Europe, here in Germany, 1,200 to 1,500 euro per needle. So that's also a point that you have to keep in mind. The other option, and that's what we're going to talk today, is brachytherapy. This is like a solution for a lot of problems that we have seen earlier now. So in brachytherapy, you put a brachycatheter within your target. So you have the radiation from the inside. You don't have to treat a lot of tissue, surrounding tissue, healthy liver. And also when the patient is breathing, your brachycatheter and radiation moves with the breathing of the patient. We started our program here at LMU in Munich with the liver brachytherapy program in 2017. That was when Professor Ricke, he's the chair of the radiology, he came here to Munich and became the new chair of radiology. Before, he worked in Berlin and in Magdeburg, where he already started doing liver brachytherapy also. By now, we were really successful. Recently, we celebrated the 1,000th lesion, liver lesion, which we treated since we started 3 years ago. In our brachytherapy department, we have Flexitron from Elekta, as you can see here in this image. We also use the Oncentra Brachy treatment planning software. And usually we're one radiation oncologist, one senior radiation oncologist, one resident. We have one physicist and 1 to 2 RTTs. Last year, we treated 320 patients and we did about 650 fractions. Most of our patients are liver patients, and we also do a lot of gynae and also skin cancer, for example. So now I'm going to show you our liver brachytherapy procedure, how we do it in our institution. If you're going to plan to do a similar program, I always say that everyone has to do it the way which fits best their own clinic. So what I'm going to show you is just one way how you can do it, but obviously there are many different ways and everyone should find the best way which fits to their own department. In our department, we do the brachytherapy of the liver in cooperation with interventional radiology. The radiologists obviously are really skilled in placing catheters or doing biopsies or also doing own interventions. So that's why in our case, the radiologists are doing the putting in the brachytherapy catheter, and then the patient is moved to our department, and then we do the planning and then the treatment itself. Here is the setup which we use. So we do it in the CT under fluoroscopic mode. These are the catheters we use. So we have in white, that's an angiography sheath, which is also sutured to the skin of the patient. And inside, then we have our brachytherapy catheter. The brachytherapy catheters are from Primed, and you see it's like 30 euros per catheter. So if you compare this to an RFA needle, there's a huge difference. We use a Seldinger technique, which means that first a needle is put into the tumor, and then we put a guide wire inside the needle. We remove the needle, and then this angiography sheath is placed. And if the angiography sheath is in place, then we remove the guide wire and put in our brachytherapy catheter. Here you can see how it looks in real life. So you see the needle already inside. Within in the needle is the guide wire, and then over this wire we put this angiography sheath, and then we remove the wire, and the blue one is our brachytherapy catheter, which we then put in place. Most important thing is you have to number your catheter if you use multiple catheters. Then the patient is transferred to the radiotherapy department, and we as physics is doing the catheter reconstruction. Our catheters have a radio-opaque tip, which is very good. So on the CT, you can see the tip. And you see already in this image, if you want, like this lesion was in the liver dome, so you have to do a very angulated catheter insertion to avoid the surrounding lung. So that's already very tricky if you're not an expert in doing this, to do such angulated implants. We then reconstruct the entire catheter up to the skin surface, as you can see in this image. And after that, it's really important if you use multiple catheters, like in this image, that you have a good numbering of it, because it can get very crowded. So we also usually we have an image of the skin of the patients, where we look which catheter number exits the skin, and then we correlate that with our reconstructions so that you don't mix up any catheters. We then do the planning and dose optimization. Usually we do it manually or graphically with the Brachy treatment planning software. Sometimes in very complex targets, we also use the inverse planning tool, HIPPO, which is always a good start if you have a lot of catheters and a very complex target volume. One thing I want to point out is that in our institution, we always also treat the puncture tract. As you can see in this image, we have a very low dose of around 5 gray. We put into the entire treatment tract, the needle up to the skin. In the preparation of this talk, I looked for the literature, and I found this very recent study from Berlin. They had a look at their last 1,760 interstitial brachytherapy procedures, and out of them, in 400 cases, they treated the puncture tract. In all the others, they didn't. And what they found is that overall, in 1.5%, you have a seeding in this puncture tract. They didn't see a statistically difference if you treated it or not. So basically, literature is saying you don't have to. In our institution, we always treat it because you put the catheter within the lesion, and so there is some risk for seeding. And also, like radiology, if they do RFA, they also treat always the entire canal. So we also do this in our treatments. Brachytherapy, the planning then. Usually we don't add any margins on our CTV, which means CTV is equal to the PTV. Our prescription dose is 15 gray in HCCs, 20 gray, also single fractions, so one time, 20 gray in metastasis, and in colorectal metastasis, we use a higher dose of 25 gray. These are roughly our constraints. Most important constraints for the healthy liver, where we usually try to have the volume which receives 5 gray below 66% of the liver, and the volume which receives 10 gray below 33%. I have to say that for us, it really depends also on the liver function. So patients with HCCs sometimes have like the liver function is not so good. There we take more caution, and in patients with metastasis, we know it's less a problem. Why we look at this? Obviously, there is a risk for radiation-induced liver disease. As you can see in these examples from literature, if you do your brachy, and that's done an MRI with hepatospecific contrast agent, and you can see then that the hepatocytes, you have this lesion. It usually corresponds to your 10 gray single ISO dose, where you can see then these reactions. Like in this case, here below, where the number F is, you see that the dose was really large, and then also in the follow-up, you see a very large injury of the healthy liver. What can you do? There are some measures. You can do a RILD prophylaxis. We usually give it in patients where we have a really high liver exposure. And there is really a randomized trial on this. And they gave patients this prophylaxis or not. It contains 3 drugs which you give to your patients for 8 weeks after the brachytherapy. It is enoxaparin, pentoxifylline, and ursodeoxycholic acid, and you give this for 8 weeks. And they had to stop this trial prematurely because patients who received the medications had a significantly lower risk for a focal RILD. So it was 45% versus 90%. So if you have patients with a high liver exposure, we usually give this treatment for 8 weeks. You can read the details in the study, which I added there. Then when you're done with planning, obviously you connect your transfer tubes. You're all experts in brachy, so that's nothing special. And then you do the treatment delivery. I only wanted to point out that treating times are a bit different than what you're used to if you do prostate or cervix or other stuff, because you can have very long treatment times also. So if we have very large lesions and with which you're going to treat with 25 gray, and if your source is not like super new, such a treatment can also last 90 minutes beam on time. So that's like a really long time. We now change our source every 6 weeks as the time, otherwise it's too long for the single treatments. Then I wanted to show you why we use the Seldinger technique, because basically you can also do a direct puncture of the liver, obviously with a brachycatheter. And we use the Seldinger technique because at the end, when brachytherapy is done, we remove the brachytherapy catheter out of this angiography sheath. And then we use this angiography sheath to put in some gel foam, which you can see here, which we can then put through this technique into the puncture tract, which can prevent bleeding. So to come back to the hepatocellular carcinoma, the indications are in case of inoperable HCCs, which have an indication for a local ablation. And of course, it's an alternative treatment to the radiofrequency ablation or microwave ablation. Here, a nice example of a HCC in segment 1. Here you see the brachytherapy catheter in the middle image. And then already after 3 months, you see a very nice response. So when do we decide to give a RFA or a brachytherapy? Usually we prefer brachytherapy over RFA, especially in exophytic tumors which are not like very nice and round. In tumors in the hilum, and also in tumors which are close to large vessels, because as you know, in RFA, you can have a cooling effect, and in brachytherapy, that's no problem for us. Brachytherapy is also better in like closed organs at risk, as you can see in the upper image. That was a lymph node close to the stomach, or if the lesion is close to the bowel, or also other like colon or heart, and also in lesions which are larger than 2 to 3 centimeters. We use it as an alternative to SBRT, mainly in cases where we have multiple lesions or if we have very large lesions. Here are some examples, as you can see here in the upper right image, where we have 2 lesions, or here below a lesion which was like very close to the stomach. And here we put also a balloon in to put the stomach away from our dose. So that's also something you can do. Here I have 2 examples of some very large lesions, and you can see you need more catheters, but that's also doable. This is a patient which has 3 lesions overall, so we made him come twice. We first treated these 2 lesions, and then for the third lesion, he needed this balloon, which is like a balloon you need for you use for a dilation of the aorta, and you see that here the stomach then was distanced from the liver, and we could also treat the third lesion. What about the clinical results? There are some data published. That's just an overview. I'm going to show you a little. So this is a study from Berlin where they evaluated 200 lesions. The local control rate is really good, so over 92%. And what's typical for hepatocellular carcinoma is that your distant hepatic control is not so good, as these patients tend to have then in the follow-up also new lesions within the liver. There is some randomized evidence also for brachytherapy in HCC. This trial randomized brachytherapy versus TACE. And what you could see that are the results, it's that the time to untreatable progression was better for brachytherapy, which is the yellow line, than TACE, which is the blue line. But if we go to the very right side, this is the overall survival. It has no impact in the overall survival. Usually that's because then you have a crossover, so patients which have a progression on TACE then finally get brachytherapy or other local ablative treatments. That's why the overall survival stays the same. If we go more into detail and we look at the different BCLC stages in this study, you can see that the very early stage HCCs, there was no difference between TACE and brachytherapy, but brachytherapy was mainly better for the more elevated stages, BLCB and BSLC, where it was superior. If you have a look at the toxicity of the 2 modalities, you can see that the grade 3 events were the same. So it was 5 to 6% overall. So there was no significant difference between the 2 modalities. Then brachytherapy as bridging prior to liver transplant. Also here, this is a retrospective analysis where they analyzed also if brachytherapy was better than TACE. And what they found in the explanted livers was that the pathological outcome was much better for brachytherapy. In TACE, 60% of all patients had only minimal or non-pathologic response, while in brachytherapy, the rate was much, much better. If you look at the recurrence rate after liver transplant from HCC, there was, if the patient was transplanted within the Milan criteria, then patients who received brachytherapy as bridging had no recurrences at all, while the TACE patients had some recurrences. This is an example of a very large HCC. You see in the arterial phase, You have a lot of contrast. Here are already the brachycatheters. Then this is the first follow-up after 3 months. You see already the shrinkage of the tumor. And then after 9 months and after 18 months, the tumor is like completely gone, and you already see the colon here below. So that's a very good result. So most people ask me, why you do brachy, why don't you do SBRT? So that's a very common question. I tried to give you an overview on this slide. Mainly you can say brachytherapy is minimally invasive, while SBRT is not. But if you use fiducials, then I would say it's the same. Then it's also minimally invasive. We have much smaller volumes in brachytherapy because we don't need any additional margins for PTV. For SBRT, it depends on your technique, but if you use an ITV approach, then you have much larger lesions, much larger target. You have to treat a lot of healthy liver also. In brachytherapy, we do a single fraction, which is really good for your patients. In SBRT, usually for liver, you do 3 fractions or 5 fractions, so the patient has to come back multiple times. In brachytherapy, we have a very sharp dose gradient, and our low dose spill is usually limited. And we also have an inherent dose escalation within the target. Obviously, we're close to the catheter, the dose is really high. In SBRT, you can have this if you want, but there are also some people who do very homogeneous SBRT treatments. Now lately it's going, some do more like this dose escalation in the middle of the target, which is like mimicking what we're doing in brachytherapy. In brachy, we can treat very large liver tumors also. I'm also going to show that later. And the question is always, do we have less dose exposure? I say yes, because we have smaller target volumes. So we did a planning study with 85 patients with the colleagues from Magdeburg and Hamburg. And the comparison was brachytherapy versus SBRT. The study used an equal prescription dose, so both studies used either 15 or 20 gray prescription dose, 15 for HCC and 20 for metastases. And what the study showed is that if you have the higher dose, so the 20 gray group, you can spare more liver using brachytherapy as compared to SBRT. We did a similar study in our institution. I just want to share this with you. Basically, the most important factor is always your implant. I have this example for you. So you see here, that's a lesion directly underneath the heart. Here's the heart. And the catheter is very close to the heart, and that makes it very difficult to treat the entire lesion, and therefore you can only treat a part of the lesion, and the patient usually has to come back and you have to do a second treatment. Another problem which you could have is that if you have 2 lesions which you treat very close to each other, also in brachytherapy, the dose can go together, and you can have a higher dose exposure if it's really close to each other. Here, a patient from our clinic, a 76-year-old patient with HCC. He had these 2 liver lesions. And here is the brachytherapy. You see in the arterial phase, you see the HCC is really good. Here, the catheter was not perfectly within the lesion. The intervention is done without contrast, only with the fluoroscopic mode. So usually it's all you work with anatomic landmarks, so it's not that easy always to get a catheter where it should go. Here you see it is like next to the lesion, but the volume is still okay, so we treated the lesion anyway. Our own data, I'm just briefly showing you that you get a feeling for which patient you can treat. These are HCC patients, and these are mainly male patients. Usually we had from 100 lesions, 15 patients were on the waiting list for liver transplant. Usually the child score is like A or B. Otherwise, the liver function is not good enough and you should not treat these patients. Also, the platelet count usually is then also not good, so it would be too risky to treat these patients. We have here all patients with 1 to 3 lesions, and what you see is the number of catheters. So we used 1 to 5 catheters in these patients, and I show you this data because I wanted to point out, if you have a look at the GTV volume, you can see the smallest lesion was like 1 cc, but we have treated also HCCs up to 280 cc's, which is pretty large. If you have a look at our dose, which we applied to 100% of the CTV, PTV volume, you see that the mean dose is 15. That's what we prescribe. But there are some cases where we cannot reach the 15 gray, where we have to reduce the dose because one of the constraints is not fulfilled, and we have to spare something because of the organs at risk. These are patients where sometimes then you do a second intervention during the follow-up. But the D90, as you can see, 90% of the volume is much higher. So sometimes it's also enough and you can do the follow-up and wait. These are our local control rates. Very early follow-up, the recurrence-free survival was also 92%. If patients don't have a progression in the liver, so if they don't have any new metastases, usually also the treated metastasis is controlled and has no progression. And as I have shown earlier in the other data, the hepatic progression-free survival is typically for HCCs. So these patients will have new lesions and they will be treated again, or if it's like distant metastasis, then they go into systemic treatment. This is an example of big lymph node bulk in the liver hilus, and you can see here our brachytherapy catheters. This was our dose distribution, and the good thing in HCC is the response is really quick. Usually this is the follow-up after 3 months, and you see already a very, very good response. Briefly about the liver transplant, we had treated 15 patients on the liver waiting list for liver transplant. 5 patients actually received the liver transplant. The others are still waiting. And we had a look at these 5 patients who were transplanted, and 3 had no residual disease, while 2 patients had some response, but still some HCC there. But that's a very good result. That was the first part regarding the hepatocellular carcinoma. Now I will briefly also talk about oligometastasis. we want to treat the patients who are oligometastatic, which means they have only a few metastases and are not a disseminated metastasis. There are different definitions. So oligometastasis de novo, or as a recurrence, or after systemic treatment, if they have one progression, for example, that's oligoprogressive disease. Is this a new paradigm in radiotherapy? I would say yes. I'm going over this a bit quicker now. I think all of you have seen this already, the new studies we have regarding this. So the study by Gomez with NSCLC, so lung cancer with less than 3 mets, where they found the overall survival if you treat all the metastases. And similar also the Saber Comet study with up to 5 metastases, where these are very impressive curves, where if you treat the metastases, you have a much better outcome. For liver, we have similar study, which is not so famous for RFA. It was colorectal cases with less than 10 liver mets. And also here, the curves are very similar. You have a survival benefit if you do RFA on the liver lesions. RFA, I showed this already before, is only good for limited size to 2 to 3 centimeters, and not if the lesions are close to great vessels. Otherwise, SBRT or brachytherapy would be better. Also here, brachytherapy is already in the guidelines. That's the ESMO guidelines for the treatment of metastatic colorectal cancer. We call it toolbox of ablative treatments. And you can say, if you have a look at the local treatments, the non-thermal local treatments, you have brachytherapy as a treatment option, and you can offer this treatment to your patients. Also in liver mets, obviously surgery is always the first treatment option, and if patients cannot be treated, then you have can do the other local ablative therapies like RFA or brachytherapy. Also here we have published data, and just briefly I want to show you our patients, which a student evaluated. We had 106 patients. We did 140 brachytherapies, and it was some patients received up to 4 fractions, so 4 treatments, and the lesions were 25 lesions were very large, so over 6 centimeters. And here the histologies, so colorectal is the most common, but also pancreatic or breast or sarcoma or lung cancer. You can see that sometimes you use a lot of catheters, so up to 9 catheters, and we mostly did 1 lesion, 2 or 3 lesions per fraction. But if the patient has 5 or 6 lesions, then we do like 2 or 3 treatments to treat them all. The prescription dose, it's higher than for HCC. So you can see here the mean is 19 gray. But what I wanted to point out here, if you have a look at the D50, so the dose of 50% of the volume, that's already 50 gray in single dose. That's a very high dose. That's why we have very good local control rates. The complications of this 100 patients, we had 3 cases with a poor implant, where we had to do then another treatment to treat the part of the tumor which was only partially treated in the first implant. We had 1 catheter dislocation, which we also had to do a retreatment, and we had 2 bleedings. One of it required an intervention. This is also good if you work together with the radiologist, because they are the ones who are also doing then the angiography to treat the patient. Here's some examples with the same technique. You can do also lymph nodes. Here, that's an adrenal gland metastasis. You can also do kidney tumors. Here, an example of lung metastases, of local recurrences, or here also a mediastinal lymph node. Problems. So obviously the most important factor is always the implant itself. If you start such a treatment and if you do it together with radiologists, I would recommend that you do pre-planning, which means that you sit down with your physicist and you talk to the radiologist and you make like a pre-plan, which means you use the imaging and you have the diagnostic imaging, you put it into your treatment planning system, and you just make a virtual brachycatheter where you think that you would put it, and then you have a look at the dose distribution, and also if you see you need more catheters, then you can plan where to put them. And that's very good if you have large or really complex target volumes. And for the catheters dislocation, if you would have, it would be a dream, in-room IGRT solution, that would be great. So as a conclusion, I can say that brachytherapy is a very good tolerated and very effective treatment for HCC and for metastases. It is a very good alternative to RFA and also to SBRT. It is we do it in close cooperation with the other disciplines. All of our patients are discussed in a multidisciplinary tumor board, and a good patient selection is key. And if you plan to do such a program, then you have to see which resources you have in your own clinic and find the best way how to solve it. Thank you very much for your attention. I hope you have enjoyed it, and I'm happy to get some questions.
Well, thank you very much, Dr. Corradini, for your presentation. It was magnificent. There are already some questions from the audience. So, in your experience, which patients would you definitely not treat?
Usually it depends on the liver function and if they have anticoagulation or not. So sometimes, obviously, they have a higher risk for bleeding. So also, as you have seen, if you're used to do, like, for example, breast cancer implants, there we have a very homogeneous dose distribution. Our catheters are very good aligned, 1 centimeter one from the other. And in liver brachytherapy, the implants we do less catheter than we do in other treatments in brachy because of the risk of bleeding also, which means we accept higher doses close to the catheter, but then the risk for bleeding is smaller. And that's why also patients with a not so good liver function, or if the platelet count is already not so good, they are the patients where you should really think if you want to do the intervention or not.
Okay. Well, another question for the pathway when you insert the catheter, do you differentiate the dose from the prescription dose? Do you use another dose or just prescribe the 100%?
In the puncture tract,
Exactly.
we usually use like 0.8 seconds per dwell position, so a very low dose, and that's usually enough to get around 5 gray around the catheter. So it's much less than in the lesion itself.
Okay. Have you ever performed or regularly performed brachytherapy for patients with hepatocellular carcinoma, which also had portal vein tumor thrombus?
It is usually that's a higher stage then of HCC, which then usually gets systemic therapies more. but basically it's not a real contraindication.
Okay. In your experience, do you consider that also brachytherapy plastic needles could be used instead of the angiography sheet?
So we use a real needle to puncture the liver first. When you use only plastic needles, I think you need to have sharp needles, and they have to be, the most important thing is they have to be coated. Not every needle is good for liver. Otherwise, it can be very painful for the patient.
Okay. About the follow-up protocols that you follow, how often do you acquire images for these patients?
Usually every 3 months, they have a follow-up imaging.
Okay. There are also some. There's also another question. Would you consider to use ultrasound guidance for placing the catheters?
I think there's some. It depends on what you're used to. If you're really good in ultrasound and you're really skilled, I think that's a very good option how to do it. It will not be, maybe not for every lesion, but if you're very trained with it, you can, I'm sure you can also do it with ultrasound.
Okay. Which recommendations would you give for a team that would be willing to start their experience?
So if you plan to do it like we did, together in cooperation with radiology, then I would say the best thing is that you like talk together, you sit down, and there is a lot of literature you can use. And basically you have to plan how the logistics will be, who is doing what, and then plan everything together. And we also plan to do a workshop next year together with Electa, Brachy Academy, and so maybe that would be also an opportunity.
Great. Would you consider some kind of spacer, like a Fogarty catheter, intravascular catheter, for as a spacer for placing the catheters?
So we use these spacers to make a distance from our dose to the organs at risk. So we put this spacer in between. So then, for example, if you have the stomach attached on the liver, but the liver, the target volume would be that the dose goes into the stomach, then we put this spacer in between.
Okay. Do you have some protocol or a procedure for hospitalization after treatment?
Usually the patient stays for stays in the hospital for 1 day after the intervention, and we do an ultrasound to see if we have some bleeding or not, to rule out that you have some bleeding.
Okay, and I think this would be the last question. Do you have any contrast injection protocol for the guided implant?
No, so usually you do a planning CT scan before the implant with contrast, and then the implant itself is in the fluoroscopic mode, and that's then native, so with no contrast during the intervention. So first you have to see where the arteries are, and then you do the intervention with only with some anatomical landmarks, basically.
Okay. Oh, usually, how would you decide how many catheters would you place?
Yes, as few as possible.
Yeah.
But it depends. Sometimes we also So you can do a pre-planning. If you start doing this, pre-planning is really helpful. So you do you take a diagnostic CT, you sit down with your physicist, and you just make a perfect dose distribution with some virtual catheters. And then you get like a feeling on how many catheters you have to use. But keep in mind that we don't use as many catheters as we use in other brachytherapy treatments, because this high dose in the middle is okay in liver if there is no organ at risk at this point.
Yeah. Do you perform this pre-planning usually or not routinely?
Not anymore. We did
Okay.
not for liver, routine cases not, but we still do it if we do some other complex like recurrences of sarcomas close to the myelin or something. Then we also do it, because then it's really helpful. But for liver lesions, we did it at the beginning, but not now.
Okay. These are the last questions. So, how many lesions have you treated simultaneously? So, maximum lesions.
So I would say it's not the number, but it's the volume and the dose. So it depends. If it's metastases and they're very small, you can treat like really a lot. It's still the most important factor is always the liver, the dose of the healthy liver. And so that's why we sometimes split it. So we do 4 lesions in one intervention, then we wait 2 weeks, and then we do like the other 2 or 3. So you can split it into different fractions, basically.
Okay. Do you have any experience with a low dose rate?
No. So we only use HDR for these treatments. No seeds experience with it. But there are some data if you look at the literature.
Okay. David, do we have any more questions?
Yes, we have Dr. Bradley Pierce that raised his hand. Maybe he can turn on his microphone.
Yes. Hello, Dr. Corradini. Thank you very much for this presentation. It was very nice. I like it very, very much. You also showed indeed you compared SBRT to brachytherapy, and I presume you are meaning, say, doing SBRT on the conventional way with fiducials. But also know you're also quite very active with the MR-Linac, so you're one of the lucky ones that can using MR-Linac, and you're still also doing brachytherapy. So my question is, how do you differentiate, so which patients you were treating on the MR-Linac and which patients are still maybe just better treated with brachytherapy? I mean, in some way you can decide between these two options.
Thanks, Bradley, for this question. So yes, I'm in charge of the MR-Linac now also. So I have the direct comparison. And with the MR-Linac, we're also lucky that we can keep the volumes very small, because all the treatments are in breath hold. And so you can be very tight with your PTV margins. And so the argument that you treat much more healthy liver with SBRT is not really true for MR-Linac. So what we are doing basically is, I see a lot of frail patients, so elderly patients who have like some comorbidities, mainly like heart stents or like valve replacement, and they're like on anticoagulation. and it would like harm them a lot if you change the anticoagulation to some heparin for like some days, and then they have to do the intervention. And in these patients now, we sometimes prefer the MR-Linac over brachytherapy because it's non-invasive then, and
But
we can do a really good treatment.
But still, you have say a preference for brachytherapy.
For the other patients, usually yes, because it's only a single fraction. While in MR-Linac, I do my like by now the shortest regimen is 3 fractions, and so it's a single fraction in brachytherapy, and that's quicker for.
Okay. And may I ask another question if there's time for this?
Yes. No worries.
Yeah. What also about the dosimetry, you're showing, say, a lot of the D90 values, which is very high, very nice. But I was also questioning myself about, say, the coverage. Say, let's say the volume that is covered by the 95% of the dose of 90%. I mean, you're also able to cover the whole lesion completely, or because it's a quite complex implant, so I can imagine that it's not always happening, but I don't know.
Yes, so usually our aim for all our treatments is always the D100. So it's really, you have to fully encompass the entire volume of your target. And we only show the near minimum dose, because that's like what you know from SBRT or other treatments. But in the clinic, we only have a look at the D100. And sometimes if the organ at risk is like really attached to your target, you cannot always reach the 100, the dose, the prescription dose around your entire target. And then you reduce the dose, because obviously the dose is so high that you really can harm the organ at risk if you put too much dose in it. So we never do that. And so either you do then a second implant where you treat the volume which was missing a part of the dose, or you can go, if it's like nearly okay, you can also like do a follow-up and see if it was fine anyway. There's this insecurities also in target delineation, so it's always like a trade-off of many different things.
Thank you very much.
May I add some question? In this sense, do you use some index like the coin, so some conformity index to assess this?
Not in the clinical routine.
Okay. Good.
Obviously, the implant is not always perfect, and you have so there is, if the catheter is not like precisely in the middle of your target, you will treat some healthy liver, which is like next to it, to treat the entire target, but still the dose is less than it would be in SBRT.
Exactly. Yeah. Okay. So is it also routinary for you to re-implant if the placement is not perfect, or you would just rather treat it with some healthy tissue?
If we, sorry, I didn't get it, the question.
Yeah, if the implant's not precisely in the middle of a lesion, would you rather relocate or just treat with healthy tissue?
We don't relocate usually, because so you never, if you put the catheter in and it's not perfect, usually it's not recommended to pull it out, because then you can have bleeding. So either you put a second catheter in, which is better, but leave the other one also there, or you, if it's only like within the liver, then you can try to treat the lesion anyways.
Okay, I think that's it for the questions, right, David?
Yes, we have time for one more question.
Yeah. Okay. Okay, we have another question. So, how do you spare vessels or bile ducts on the CT fluoroscopy?
Yeah, that's very difficult. Basically, that's why we do it together with radiology, because they're really trained in it. And there are a lot of lesions which are not so challenging, which you can reach easily, and which where that's not that much of a problem. But if you do like segment 1 or stuff like which is like very central also, it's really tricky, and that's why we say everyone should do what they can do best. And so radiology is really good in putting in catheters in fluoroscopy, while we are really good in planning and all the other stuff. And that's why we do it like this. It's really tough sometimes.
Yeah.
So
well,
if you,
that was, yeah, please.
no, just saying, if you start doing this, always be there and have a look and see what's going on, because then you know how difficult it is.
Okay. I think that was that's it for the questions. Now David's taking the word for the remarks and close-ups.
Thanks, Gustavo. I would like to thank Dr. Corradini for her magnificent presentation and for having been kind enough to be with us today, considering the time difference. To all the audience for the valuable time dedicated to this discussion and for joining us, hoping that it has been of interest to you. At last but not least, to Brachy Academy for the support provided. And greetings to you all, and hope to see you in our next session in 2 weeks.
Bueno, a toda la audiencia latina, igual gracias por acompañarnos. Darle también 1000 gracias a la doctora Corradini por la charla. Estamos muy agradecidos. Esperamos de alguna forma encontrarnos en el futuro a través de este mundo que es la brachyterapia. Y esperamos que todos los que nos están escuchando y que en el futuro van a ver esta presentación se entusiasmen y puedan iniciar un programa de brachyterapia en sus propios centros y poder de alguna forma que esta técnica florezca alrededor del mundo gracias a la doctora Corradini que hoy día nos acompañó. Sinceramente, muchas gracias y espero poder verla en su centro en alguna pasantía que me pueda recibir.
So in name of Apollo, thank you for the presentation. It was magnificent. We're just encouraging our colleagues in Latin America to start these treatments or techniques, and hopefully to see you soon in your center, so you could also train us. Thank you very much once again, and I hope we could see us soon.
Yes, thanks a lot for the invitation again.
Bye-bye.
Bye-bye. Thank you.
Adiós.
Bye.